Hi, Dr. Eric again. Thank you for joining me. Please like, share, and subscribe. If you're watching live, please visit my other channel, my main channel, Onegbola Farm D, which is my main channel. I'm a pharmacist for 12 years now, as of October 2025. Please like, share, and subscribe. Binge watch on all of my videos. This particular video, I'm talking about, again, what the topic title says. It says screening and prevention of cancer and the timeline in which these items should be done. So, as we know, as we grow older, the cells in our bodies, they begin to change. Sometimes they change normally, sometimes they may change radically, meaning that they may implement other proteins, they may produce other proteins, the DNA may be altered a little bit. Some of these cells, they change based on our environment, and sometimes they can be changed based on the consumption of our medications, such as teratogenic medications, also our food intake. Now, there's a lot of research, there's a lot of media attention that's out there that talks about what may be the cause of the changes in our normal cells that are being altered to cancer cells. Doctors and researchers, we do not, as scientists, we do not always have the complete answer to give. So, in that case, we suggest that our patients, our family members of these patients, we recommend that you hone in on screening, proper screening. So, for example, males, male populations who are of the age of 40 or around about should begin prostate cancer screening. Another example, colorectal cancer prevention and screening should occur at the age of 45. It was once said that screening should occur at the age of 50, but because younger and younger generations of populations are becoming more and more diagnosed and having symptoms of colorectal cancer, we have now seen or been advised as medical providers to allow age 45 and older to receive these screenings now. The news broadcast I recently listened to, it interviewed some young adults who were dealing with bleeding rectums. They had plenty of symptoms later on with stomach cramping and not being able to have a lot of energy. They were feeling lethargic. They were just feeling fatigued all the time. In addition to the bleeding rectum, they did not know what was going on. So they went in for a screening and found out that they did have active cancer. So be mindful of the suggested timeline at which to receive your preventative measured screening. Another example, women at the age of 40, we all know, should receive a mammogram. That helps to prevent or rule out breast cancers. If we rule out breast cancer, we have more survival rates, we have earlier detection rates, and we can, as scientists, as research, medical doctors, pharmaceuticals, we can actually help with a better quality of life and long term outcome. So please be mindful of the timeline at which you are suggested to be screened for certain diagnoses. There are other diagnoses out there: high blood pressure. Patients who are of the age of 30 or so, 35, should be measured for high blood pressure. Um, High blood pressure is not, of course, a cancer diagnosis, but it can be a symptom of such. Nausea, vomiting, bleeding, acute pain, chronic pain, um, weight loss. These are all natural signs of cancer. These are all natural signs of possibilities of growth of cancer. Now, another symptom that I want to mention, I don't want to forget about, is inflammation, swelling, such as lymph node swelling. Lymph node swelling is a sign of cancer as well. Bulging, uh, abnormal bulging in certain areas of the body. Swelling again, fatigue, lethargy, weight loss, nausea, vomiting, excessive sleeping, excessive, just being excessive in a way that's not normal to you from day to day. These are signs that you may want to have a primary care physician, a PCP, a nurse staff to evaluate your particular circumstance and to know whether or not you are in position to have a stage 1 through 4 diagnosis. The later the stage, for example, kidney disease. Kidney disease has 4 stages: stage 1, stage 2, stage 3, and then stage 4. Most cancers that are in stage 4 are detrimental and life threatening. There's really no comeback from a stage 4. That means that the cancer has progressed, it's grown, it's deepened into tissues, it's deepened into bone marrow. It's gone to an extent where the last resort is the body to just completely break down. The earlier the stage, the increased likelihood of a prognosis that is likely to be favorable. Again, stage 1, stage 2, you have room for reversal. You have room for treatment, whether it be chemotherapy, whether it be surgery, whether it be radiation, whether it be um, medication therapy for chemo treatments. So the important thing is not to focus on the treatment, but to focus on the prevention, the actual diagnosis. We have medications. As a pharmacist, I've seen medications being dispensed. Um, those who have chronic conditions, chronic diseases, we see more of that in the inpatient um, pharmacy, more of the inpatient hospitalization, hospice care patients. Retail patients, community patients, our community pharmacies, we don't see so much of that. We don't see so much of the cancer distribution of medications. It's more so done in house. Again, hospice, hospitals, chemotherapy appointments. These medications have side effects. They have great outcome effects. Um, they work by preventing or blocking a lot of the receptors. When I say receptors, I mean the think of a baseball mitten. The baseball mitten is the receptor. It catches the ball. So when that ball is thrown, that receptor or that baseball mitt is going to catch that baseball and hold on to it. And that means something in the stream of things. That means that, okay, I have the ball is in hand. So in medicine, the receptor or the mitten is blocked by the medication that is dispensed and consumed by the cancer patient. When that is blocked, that baseball cannot fit into that glove anymore because it's now blocked by the medication. And by it being blocked, that receptor receives a message from the medication that says, you know, hey, we're here to do good. We're not going to receive that ball, um, and we're not going to allow this cancer to grow. We're going to block we're going to be not a catalyst, but we're going to be an anti-catalyst, and we're going to allow the cell to the cell of that receptor to ultimately be normal, end quote. So medications although we have medications and they are there, these medications, they're not a quick fix, but they're dependable. They are there, and we can depend upon them to do what we need them to do, such as breast cancer, for example. Another example I can give: the estrogen receptor is blocked by the medications that help to reduce breast cancer growth. So once that blockade is occurring, then yes, their chances of breast cancer occurring diminishes. So chemotherapy is the same way. Chemotherapy is medications. Um, Medications for cancer can be IV or intravenous. They can be oral. They can be taken by mouth, consumed by swallowing. Side effects, unfortunately: weight loss, hair loss, nausea, vomiting, um, skin rash, allergic reaction, could be headache, um, to name a few. I don't want to get into too much details on this video about a lot of what we deal with, a lot of what oncologists deal with, um, and the cost of these medications. Costs are tremendous. They're in the thousands of dollars for a month supply of medication. Um, and they require safe handling as well. They can be teratogenic. The the powder or the material have to be stored in a certain way to prevent degradation or to prevent the loss of effectiveness of the medication. And there are also other medications that cancer medications interact with. So you were I don't want to say, that all cancer medications are harmful, but they're very potent, they're very specific, and they are known to have a certain effect. Case by case, the risk for a patient to take medication is outweighed by the benefit of the medication. Um, Again, there's surgeries that can do removal of cancer cells. But again, this video is not to go into the treatment, but to focus on the prevention, getting screened, being effective in consistency in your screening, colorectal, breast cancer, leukemia, thyroid, lung cancer, lymphoma, prostate, bladder cancers. Okay. Um, all of these are disease states that need to be addressed early. Okay. And then medications, I can go into that on another video. But again, check with your primary care physician to find out which screenings you are eligible for at this moment and be consistent in these screenings. So that's what I wanted to go over in this video. And I hope I've helped someone. And I hope that someone is, taking this very seriously, because a lot of the things that we deal with, a lot of the mortality rates that we deal with as healthcare providers, they're preventable through these screening processes. And they're easier. You don't have to be ashamed. You don't have to feel like you're going to be talked about or talked down on. It's very private. Healthcare providers, we know, to not disclose information about a patient. We know not to, um, make someone feel shamed at, coming in for testing or coming in for diagnosis, coming in for screening. Um, and again, the ones that I mentioned: prostate, bladder, blood cancer, thyroid cancer, skin cancer, lung cancer, breast cancer, colorectal cancer, bone cancer as well. These are the most prevalent cancers that have been detected to date, in this generation. So I'll leave that with you on this particular video, and thank you for joining me. Please visit my website or my YouTube channel, Erica Onikbola PharmD, and also binge watch on all of my videos. I talk about a plethora of medications, side effects, what to look for, the benefits that outweigh the risk. And I hope to see you on my next video. Thank you for stopping by. This is Dr. Erica. Bye bye.